Um, so what a privilege to be here, and thank you for the invitation. It's an amazing opportunity, not because I'm here in Turkey for the first time. I've been to Istanbul airport nearly more than 50 times, but it's another thing to come to a country and feel the energy. And I was sharing with Mesut earlier on, any country is as beautiful as the people in it. And I think people component makes this physically beautiful country even more amazingly beautiful. So thank you for this invitation. So I'm going to be talking about beyond the clinic, rethinking mental health access from stigma support through digital solutions. So anything what we do, because when we talk about any aspect of our life, whether we love, trust, or even digital mental health, we all have our own mental note of what it is. But I think it's important to anchor something in a definition within which we can anchor what is the definition of digital mental health. And nobody else other than an amazing colleague at the Black Dog Institute in Australia and Sydney, Helen Christensen. She coined a term, mental health services and information delivered or enhanced through the internet and related technologies. It's very broad, because a lot of times when we think about e-mental health or digital mental health, people immediately gravitate to apps, because as if apps is the only thing that digital mental health ecosystem is made up of. So once we've settled on a definition, but if you go around the world, and not two countries are using the same language in what we call it in those countries. So in UK, Canada, the most commonly accepted term is digital mental health. In New Zealand and many other countries, it's e-mental health. In the United States, it's digital therapeutics. Some countries, it's a blue prescription. So what we're talking about is the same thing here. So looking at the naming conventions, how vastly different they can be. But also, digital mental health is not just about the clinician-facing elements, which are EMR systems, a lot of AI diagnostic tools built into it. So they are amazing solutions which are clinician-facing. But majority of the trend where the excitement is coming is looking at the patient-facing element as to the consumers. And I'm also very mindful of the language, because in some countries, using the word patient would not be seen as welcoming. So some countries have to use the word consumers, mental health service users. So I need to be very respectful of the local culture and local acceptable terminology that is acceptable to the local community of interest. So we're talking mobile apps and websites, AI technologies, helplines, online communities, clinician tools, digital therapeutics, VR, wearables, EMR systems. So list goes on. Just wanted to contextualize that within the lived experience perspective. The three examples I'm going to give. I'm going to start with the Amber Leroy, the number one, number one, even though it's listed as number 3 in the slide. Amber Leroy, she lives in Clarenville, Newfoundland and Labrador. It's the easternmost province of Canada. And she was with me at a ministerial, all the provincial ministerial mental health meeting, where she came along and spoke about her having made 3 attempts on her life. And every time her parents called the ambulance, she got taken to the emergency department, got given the care, and then got sent back home. And she said to the group of these ministers, but I was being sent to the environment which was the cause of my distress and the steps I was taking in self-harm. So it was not solving the problem at all. So she was sort of saying, all right, so that's one thing. The 4th time she decides that she was going to finish it for once and for all. And she got a big knife out, and this time around she was going to really bring it to an end. But then on Saturday morning at 3 a.m., she decides to reach out to her phone. She comes across an online service, which she rang them, and she had the most amazing conversation with some person at 3 a.m. in the morning. And she says, we all know that in mental health, the power of listening, the power of empathy. We all know that, what a big role it plays. But she said somebody had lifted the lid off this pressure cooker. She said, and she felt as if life was worth living. And she said, challenged all the ministers of health, they were provincial ministers, but she said, you are busy building the physical, traditional mental health support services. To me, that is mental health. That's the only way I know how to access mental health. She said, I got no stigma against mental health, but reaching out to the traditional mental health support did not even cross my mind once. And she said, even if it would have crossed my mind, but what is available at 3 a.m. in the morning, on Saturday morning? So her point was, if the service was not there when she needed it, she may not even be alive to speak to the group of ministers. So I think that is one message that I want to park for a few minutes here as to why it is important to have timely access. That is the important thing we're talking about. Sorry. So the other one is, there's a number of colleagues here from Netherlands. And I was at your emergency hotline. I just talked about the number of calls they take. And towards the end of the day, this is the amazing facility in Amsterdam. And they talked about, so I asked them, of the completed suicide in Netherlands, how many of them are known to the Dutch healthcare system? Number is, out of 1,862 completed suicides in 2023, only 40% people are known to the healthcare system. 60% did not reach out to seek help. Now, there is a lot more data behind all of these things, but what we're talking about here is when I compare that access in Australia and New Zealand and Canada, in Australia, that 60% is 72%. So it is no better off in any other country either. So what we're talking about here is, what does the good look like in terms of how do we make a mental health services available in a country which is meeting the needs of all the 100% of the population that resides there, not only the people who are seeking out and going to the traditional mental health support services. And Australia, so this is a federally funded program. It's called Systems Navigation, and it is $113 million a year, and it's a baseline funding, and this is looking at systems navigation. How do we make services available to the people when they need it? So your cognitive ability to navigate through what's already there. It's not that there are lack of services. I'm sure that Turkey has got amazing services as well, but if people can't get to them when they need it, that's the thing. And if they can get to it, probably they will be fine. But the thing is, so you may have a financial distress, you have taken a loan for some sort of a business venture you're starting, and all of a sudden there's a drought in 2 years in a row and some crops have failed or whatever has happened, then all of a sudden you cannot relate your inability to repay the loan anything to do with mental health. So the thing is, so we need to look at how do we provide, how do we position services, how do the right people at the right point of time in or distress, they are able to access the services that already exist in the country. We're talking about barriers, we already know about that. But more important is also looking at the suicide legislation is still treated as a crime in many countries. We are talking about 18 countries where attempted suicide remains illegal. 23 countries, it remains illegal. So that has impact on who is going to access and how, when, and where. There are some amazing numbers in terms of in major depressive disorder. We know that 280 million people worldwide, 160 million people are aware for the need for treatment, and 113 million of those will seek help, and 46.2 million receive minimally adequate treatment. But in low to middle income countries, the number is only 3.7%. So what we're talking about is the numbers are pretty staggering in terms of the need as opposed to how many people are able to access or reach out to services. So looking at the global challenges, so this is work which I'm doing with Amina J. Mohammed. She is Deputy Secretary General of the United Nations, and Honorary Julia Gillard. She's a former Prime Minister of Australia. She's also the chair of Wellcome Trust. They fund a big program of work at the United Nations. And so, so it was a privilege to be part of a process and that the United Nations Security Council resolution on mental health, which was passed on 26th of June 2023. And it's got a digital mental health component built within resolution now. 2025, this year, there's a review of the resolution where digital mental health component is going to be further strengthened. So some of the project which Amina as sort of a new program of work is looking at humanitarian settings. 300 million people. These numbers are staggering. You know, we're talking about 66 million people of those experiencing mental health challenges. Now, majority of these people do not have any food security, shelter security, none of that. And I was made aware that, which I was, made a sad note, that Turkey happens to have the world's largest refugee population in the world. So you know what I'm talking about here. So these people have no shelter security, food security, but even in the harshest of the harshest environments, majority of these people have a smartphone, because that is the only lifeline that connects them with their loved ones, whichever country they may be living in. So the program of work at the UN is looking at how do we look at the touch point, because some of these countries we're talking about, there are two programs coming up, one in Lebanon, another one in Sudan. So there's going to be looking at phone-based, how do we create the touch points, because there is nothing else physical infrastructure-wise that could enable the access. So we are looking at the marginalized groups, LGBTQ, sex workers, children, adolescents, women and girls, people with disabilities, ethnic and religious minorities. Some of the work which we are doing with Dr. Zainab Hijaji, and also ICARO region, which is based out of Geneva. So we are working with them, developing international expert advisory group, which Andy is also part of that one, and EMIC is a main instigator behind establishment of the group, and we are looking at the development of digital mental health guidelines for adolescent and youth. And that is, while this particular piece of work is going to be for European region, 57 countries, and some of the projects where they have been deployed is in Kazakhstan, Ukraine, and Poland as well. So there is some bodies of work happening, but fragmentation, because each 7 regions of the UNICEF work stand alone. So it's a bit of a challenge to make sure that what happens in one region can it be replicated in other region as well. At WHO, you would know, most of you would know Deborah Kestel, the mental health in Geneva. And the biggest focus over there is looking at the improving access, looking at funding, lack of interagency coordination. But I was in Bangladesh early last year. When I was there, they told me about 172 million people in the country. 114 million of those live in the remote and rural areas. They only have 400 psychiatrists in the country for 172 million people. And all 400 of those people live in the main city centers, main urban centers. And nobody wants to go and live in the rural areas where 114 million people live. And so the statistics are that there is zero help for the 114 million people. So when I did ask the chief psychiatrist of Bangladesh, what is your one vision? And one of the vision is, the majority of these people have a smartphone. Doesn't matter the newest one model, but they have a phone. So how do we improve access using the digital tools? Because there is no other way, even if you double the Ministry of Health budget and make it 800 psychiatrists, but if 800 of them are still going to live in the 4 major centers, it's not even touching the surface, not solving the problem for remote and rural areas. So when we talk about the digital mental health, we talk about optimal activation. What does a good look like? So we're talking about here is a bedrock of the any digital mental health implementation is looking at, is a fundamental statement I would like to make here is, if it does not work for the person with the lived experience, their families and the carers, then it does not work at all. Forget about the fancy gadgets and shiny object. But it needs to work for the person with the lived experience, their families and the carers. It needs to be as simple as that. Now, so what does the authentic co-design look like? Not everyone does. Some we get a consumer focus group somewhere in the design process and tick the box because we paid them some $50 gas vouchers or some sort of food, and we think we have done co-design. The reality is, what does authentic co-design look like where lived experience is woven into the design, the development, and the implementation, because they are the people who are going to use the services. So what does it look like? Then looking at also policy and strategy. I ask most nations, the chief of all countries around the world, and we work in New Zealand, Australia, Canada. A big part of our program of work is in Canada, United States, in Europe, Sweden, Denmark, Netherlands. We're talking about England, Scotland, Ireland, Wales, Singapore, Philippines, Bangladesh, and Middle East. We've got a number of countries. So I think what we're talking about here is no more a conversation only for the developed nations. This is a conversation for everyone. Now, I'm quite surprised. You know, when I was in New Delhi a few months ago, I was so impressed to see the leapfrogging. You know, they had not followed the linear methodology of going from A to B and B to C. We are still stuck in C, and they've gone to F. They bypassed the whole lot, and they integrated to the referral pathways, intake process, treatment interventions, post-discharge support. The whole thing is all digital. It's like, oh my God, so beautiful and so highly scalable. So what we're looking at here is, what does a good digital mental health policy, what does a digital mental health strategy looks like? We're talking about the standards. Australia is the leading authority on the subject in digital mental health standards in the world. We're talking about accreditation. Singapore is right now investing hugely into digital mental health accreditation and activation pathways. So there are some brilliant examples of work, what good digital mental health policy and strategy looks like. So my take on that one is always is, so are you going to get it right by design or by default? 100% of the countries respond, oh no, we're going to get it right by design. So what does the design look like? And then there's a blank look, right? Because people want to do it, but they do not know, they understand the problem statement, but they don't know what the solution for the problem statement is. So this is where we say, oh, we don't need to do it on our own. And there was a delegation from Dutch Danish Health Authority, DHA, to Australia and Singapore recently. You know, they're going there and collaborating with them, so how can we adapt what they do for Denmark? And likewise, Denmark has got a Center for Digital Psychiatry. So how can we collaborate with Singapore and Australia are more interested in taking Center for Digital Psychiatry from Denmark to their countries. So we got such a good, beautiful interplay of how we can collaborate. So that's what we are talking about here. So what does the digital policy and strategy looks like? Do we even have one? Have we started one? Do we want to do that? Because if you want to just leave it piecemeal by project, I think we'll end up with a very chaotic procurement and very disjointed system. We're looking at evidence-based. There are more than 365,000 solutions out there. More than 365,000. So who says it works? Because we know only a fraction of those meet the quality threshold. So not all solutions meet the quality threshold. So what does a good look like? And so this is where working with the academia. All the academic institutions have got a huge investment in making sure that what we deploy for the populations we serve is evidence-based and safe and effective. Workforce, clinician engagement, I think is fundamentally important to get the clinician engagement right. And when we talk about clinician engagement, we're talking about psychiatrists, we're talking about GPs, we're talking about nurses, we're talking about social workers, psychologists, and also the unregulated workforce. What we're talking about here is the peer support workers, and there's such a growing trend of the unregulated workforce also. So anybody who touches the patient anywhere in the care pathways needs to be across what we call as a clinician engagement. Because what does a workforce development look like? So what is investment in that? Industry, so whether it's Google Health, and there are amazing solutions, Calm and Headspace and Qt, and there's so many solutions out there. So I always use this analogy. The only way we can create symphony is when we let each maestro play their own instrument. We cannot just do everyone's job and create scalable and sustainable services. So this is, I always say to people, would you like to buy a car and let your children buy a car which has got no warrant of fitness, and let yourself either or your children drive that car? A majority of us know what the answer looks like. We would not let our children anywhere near that sort of a vehicle. So why we become so laxed when it comes to digital mental health solutions, which are growing? By the way, right now, 5 million people every single day use digital mental health tools around the world. Whether you prescribe them or not, they will go to the Dr. Google and download something, and 80% of those are not meeting the quality thresholds. So what we're talking about here is, as a system of care, have we started thinking about and incorporate what is right thing to do? So in terms of types of digital therapies, so we talk about low complexity and high volume. These are the well-being solutions, the mindfulness-based solutions we're talking about, generally used for the population well-being approaches. And there'll be solutions, you would be aware of Headspace and Calm. They're massive deployment across the world. So they are, Headspace market capitalization is $4 billion US. Calm's market capitalization is $3 billion US. So these are the, low complexity but very high volume. So a lot of people use them. Then we come to to moderate end of the complexity and looking at the moderate volume. So we're talking about here, generally the target segment is primary care. We're looking at, in Netherlands, there's a beautiful solution I'm a big fan of, is Thapliyal, it's called. In New Zealand, there's an amazing solution in primary care. It's called Just a Thought. And in UK and US is called Qt. So these are, they've got a beautiful evidence base behind them. They're really how you integrate them into the care treatment pathways. So this is amazing because majority of the physicians in primary care who I talk to, they want to prescribe non-medicated treatment options, but they do not know what it looks like. Where do I start? So this is where some of these, but this is, prior to that is the clinician engagement. If they do not even know it exists, how do you even prescribe these tools and services to the patients you are in contact with? Then there are high complexity and low volume. These are for the tertiary care environment. In UK, there's a Psyomics. In US, it's Chess Health. So these are amazing solutions and meeting the different needs at different points and times in care. International policy and strategy landscape. We got Australia as leading, as Andy also pointed out, in 2012, 2019, a very outstanding psychiatrist in Australia called Dr. Peggy Brown. She led this development digital mental standards for Australia. It's been fully implemented across Australia, and a beautiful piece of work. Canada has got federally 2014, 2022, and 2024. So there's amazing amount of work that's gone on in Canada, but also not only at the federal level, but also at the provincial level. And I'm a big fan of, I know we've got Senator Kuchar here in the room, but further east of Nova Scotia, where he comes from, is a province of Newfoundland and Labrador. So I worked with the Minister of Health over there, Honorary Jerome Kennedy. This is going back 16, 17 years ago. Amazing Minister of Health. And he said, you know, we got a province which is the size of 670,000 square kilometers. That's a huge province. Entire province has a population of 500,000 people. And majority of that lives in one city, which is St. John's, which is the capital. So he said, I cannot build the clinics or the hospitals for every community, small community of 200 and 300 people up the coast. And so he said, we need to find digital solutions that meet the need of people where they are. I want them, do not want to migrate to the larger cities. How do we keep the population healthy where they are? So what a great vision. The chief of mental health, Colin Sims at that time, a very brave leader. And so it requires about leadership. The question was more about leadership at the time. And I'm just so proud of Newfoundland and Labrador's, the government over there. So they have got an e-mental health strategy. It's, the name of the strategy is called Bridge the Gap. Gap with 2 P's in it. So then there is Ireland has developed last year a national digital mental health plan. New Zealand has got its own version. United States. So the list goes on, and this is not comprehensive, by the way, because I haven't updated that. But if you're interested, I'd be more than happy to share some of these things. So let's get it right by design. You know, so what does a good design even look like? So anchor digital mental health and policy, number 1. This is some take-home messages. Build digital mental health champions for change, because it ain't gonna happen. It needs to come from within. Every country has got some people who are seeing that something has to be done differently. So build digital mental health champions for change. Workforce development has to be prioritized. I just gave quite a major sort of a talk in Indonesia, Jakarta, only 5 weeks ago at a medical school in Jakarta. The Ministry of Health and medical school and dean and vice chancellor. So we're talking about the curriculum does not even reflect anything to do with digital in any shape and form. So they have agreed to build digital mental health into the community psychiatry, and then the next one will be addiction psychiatry. So I think it's amazing that change is starting to happen in different countries at different levels, different pace, but I was just delighted to see the kind of response from the university there. Foster collective ownership of digital mental health. It's not about just one person, just somebody who's developed a solution and they got a commercial offering for the market. It's not about just that, it's about the clinicians, it's about everyone in the supply chain. I talked about the lived experience also being an integral part of it. So how do we look at the improving access? So some of these pieces of work I'm talking about. Australia has got another big piece of work that's going on led by Assistant Secretary Krista Vanderhyde, looking at improving access for the people who, because the wait times are so long, waiting a day is long enough, let alone wait multitudes of weeks and months. So doing nothing is not an option. So they have embarked on a very audacious program, which is called Improving Access. Systems navigation I talked about earlier on, and focus on partnerships and collaboration, because this is not about reinventing the wheel. So much of great work happening around the world. So how do we look at value-based collaboration where 1 + 1 = 11, not 2. So it's creating high-impact outcomes. So what does high-impact outcome even look like? So what does a value-based collaboration look like? And authentic co-design, I talked about the lived experience role in the design, development, and implementation. So this year's Digital Mental Health Global Congress is happening in Toronto on 19th and to 21st of November. The theme of this year's Congress, 47 countries would be there in person, 47 countries. At a decision, we are talking about all the chiefs of the countries, of those countries, It's already started. It's a huge momentum now. And the theme of the Congress is Global Mental Health Equity, Digital Solutions for an Interconnected World. Some of you are able to come, I would welcome you. But if you are not, I think we have digital participation options as well. So we always talk about, it is not about the standards, it is about the ecosystem. We need to get the ecosystem right. Just because we've got our digital mental health standards, Australia has got the entire ecosystem. That's why they got it right, not just because of the standards alone. It's not about digital, it is about people and trust. Because if I don't trust these things, whether as a clinician or as a consumer, I'm not going to use it. So it's about people, it is about trust. So I have this philosophy, personal philosophy. We work around the world in every continent, and I just think when I'm looking at digital mental health has no geopolitical boundaries, whether it's here in Georgia, whether it be in Ukraine, it's the same landmass. We have political boundaries, but the reality is digital solutions could be, so it has no geopolitical boundaries. So I always like to refer to it as one world, one family, one future. Thank you.